Hey there, folks. Let's go for some MRIs. If you are new here, my name is Galvani. I'm a diagnostic radiologist, and I read and report scans live so we can enjoy them together. I have downloaded already the first scan of this morning. It's 8:30 in Brazil right now, and I'm going to share my screen. If you just arrived, don't forget to hit that like button and consider subscribing to the channel. It helps a lot. This is a female patient, a rather young patient. She is 23 years old, and it says she has multiple sclerosis, and this is supposed to be a follow-up scan to see if the disease is under control. So we have a November scan and a scan from May of this year to see if there is any sign of progressive worsening disease. This is the diffusion weighted sequence right there. This is the ADC map, so we can compare and look for restricted diffusion lesions. No, it seems fine. I'm pretty sure there are going to be lesions here in flare, because flare is the most important sequence in this case, and indeed there are a few callosal-septal lesions right there on the deep and periventricular white matter, also in the posterior limb of the left, maybe the left internal capsule, could be, yep, pretty much. This is really mild disease. It says on clinical history that this patient has the diagnosis already of multiple sclerosis, so I can't really argue with that. So let's just go with it and just check for new lesions. This is the susceptibility artifact weighted image, to look for crystal and mineral deposits and bleeding, old bleeding. It seems fine to me. This is T1, axial T1, best for morphology in acute bleeding as well, and to confirm a site of a malacia lesion. This is a regular T2, axial as well. Seems fine. Besides those small gliotic sites, this is the coronal for the temporal lobes. It's fine also. Nothing major. Seems really fine. So tiny lesions on the corpus callosum right there, callosal-septal regions. This is quite common. It makes sense to call this multiple sclerosis or any other demyelinizing disease. Right there on sagittal. This is very typical. See, right there besides the corpus callosum and the margins of the lateral and the third ventricles. Let's just go for a MPR, because this is a volumetric acquisition. And here we are. This is much easier to be certain of really small sites of disease just like that. So it's mostly around the supratentorial ventricular system. This is on the splenium of the corpus callosum. Might be a small lesion right there, and maybe a tiny lesion right there, which is very hard to see on the regular flare because they do this acquisitions with a 5 mm thickness, which is absurd. This is comparable to a 1990s CT scan. So it's really stupid to do such a scan right there. This should be at least a 2.5, at least half the thickness to be a proper scan, but no, they have to make it fast to make a lot of money, so they couldn't care less, and we end up not being able to see small sites of disease because they won't show up in such a thick slice. So, and no signs of bleeding. And then we have a volumetric T1 that is shaky throughout, and we can't properly evaluate. So they did it again, and it's still kind of shaky, but we can see if there is a very acute enhancing lesion. It seems there is none. Yep, no enhancing lesions. This is November. Let's go for May of this year. It seems it's a very similar scan, so I'm not going to waste a lot of time. Where is the flare? They didn't do a volumetric flare, so this is impossible to compare because we have no volumetric flare sequence here, just a volumetric T1 shaky sequence, post contrast shaky sequence. So it's not really a properly and comparable scan. So let's just report this one and get on with our lives, because this isn't going to be of much help to anyone. Just a regular multiple sclerosis scan, as bad as it's usually done. So tiny sites of gliosis on the deep and periventricular white matter of the frontal, temporal, and parietal lobes, especially on the callososeptal regions, without signs of enhancing. And there is no sign of restricted diffusion. So I hope in the next exam they do a proper volumetric flare so we can compare as much as it's possible. Let's just finish this up and get another exam. Maybe a CT scan. It seems there is something wrong with the platform today. It's kinda slow. I hope it gets better soon, so we can be productive. So this is done. Let's go for the Q. MRI. We have a left ankle. So we go from brain to left ankle. Unfortunately, it is extremely slow. Just going to do some tuning of the browser right here. Just give me a few moments to see if I can make our browsing experience a little better, because it's extremely slow. It seems we are going to have not a very smooth morning today. What can you do? Yeah, it's taking 30 seconds to open up an exam. I hope I can download it at least. Ankle template, just copy and paste. There it is. Oh, at least it downloaded. Yep. It's a female patient. Ankles, I always like to see the sagittal first, and of course it's nice to have some kind of clinical history before looking at the images. It says it's a torsion, it's trauma, probably looking for some. No, it says patient says she has arthrosis. She is 51 years of age and she has arthrosis. It's been like that for 5 years, and her ankle hurts and got worse 4 months ago. So this is for arthrosis, not trauma. Let's see on the sagittal view. There doesn't seem to be any classical sign of arthrosis, just a small effusion right there on the talocrural joint. There is some very tiny degenerative process right there, which is very common on the talonavicular joint. Nothing major. The calcaneal tendon and the plantar fascia seem fine. Slight bone edema right there. The tendons seem really fine. This should have been imaged a bit more. There is some degenerative process right there on the fibula malleolus. Might be related to a previous torsion, and maybe in a avulsion fracture. Let's go to the coronal view. There is clearly edema all over the ankle on the soft tissue parts. This is a very, very thick exam because they started too on the front, too far away, and they ended really before the tendon right there. This is so bad. Come on, man. It's a 4.5 thickness slice on an ankle. Man, they really didn't want to image anything here. They just want to do it just to make it, just go through it without making anything that of use in this sequence. See, this is just stupid. Come on, you can't just do a 4.5 thickness coronal ankle exam. This is just, oh crap, this is just freaking terrible. Come on. Come on. Oh boy. Let's just keep it up. And there is some degenerative disease right there. Just some interzophites. Tiny bone spurs related to maybe a avulsion fracture, an old avulsion fracture. That's as much as I can tell. Ligaments seem fine. Muscles seem fine. As much as it's possible to tell, because this is just really, really bad, as most of times it is. So we gotta just get used to it, keep on pushing forward. This syndesmosis looks fine, and the tibiofibular ligaments and the calcaneal fibular ligaments seem fine right there. Yep. Here too. There too. Tendon sheaths are fine. Posterior tibialis are okay. Tiny sites of bone edema on the talus and the calcaneal. There really isn't much to tell here in this exam, although it's really, really bad. It's really a low quality scan. They did it in oblique, non-saturated scan, which is stupid by itself. It makes no freaking sense. So let's just not waste our time with it. Excuse me. So we have tiny sites of arthrosis right there, some articular effusion, some deformity right there, and soft tissue edema. This is it. Let's just move on to the next one. So and tiny effusion and edema. And this is it. Let's not waste any more brain trying to figure out whatever this is supposed to be. And yep, just it seems though the platform is a bit less slow, so we might just be getting lucky. Hello Hold'em, what's up mate? Let me just pop out the chat so I can see if anyone shows up. Let's go for another exam. We have a brain MRI. Let's grab a brain MRI. It's still slow, so it's trying to load the screen. This isn't me. This is a portal. There is a previous exam. Trying to download today's exam, and I'll just download both. Let's see, it's a female patient. She is 36 years of age, and excuse me, it says she has also multiple sclerosis. And there is a very thorough report from March of 2023 saying it's a very serious exam, is very serious disease. So it's here. Both exams are here. Let's see how can we analyze it. So let's go for today's exam. Diffusion weighted sequence right there. Axial. Let's see if there are any new lesions. No. Diffusion, no bright spots on diffusion. So ADC map is not of use because it's not going to help us. Let's go for a flare. Oh, there is a bunch of lesions right there. Confluent periventricular lesions, especially on the peritrigonal regions and around the posterior horns. There is even a cerebellar lesion right there. I hope they did a volumetric flare. They did. So let's just go for the volumetric flare. It's usually what the only sequence we need to evaluate besides diffusion and post-contrast. But to localize new lesions, volumetric flare is the most important sequence for sure. This is a node scanner because there is way too much noise on such a sequence. So this hides tiny spots of disease behind massive noise. See how noisy this is? How noisy the air around the patient is. So this is a clear sign of a badly maintained scanner, a very badly maintained coil, and also the positioning is wrong because there is a duplicate artifact right there. So the scan itself wasn't properly set, which could be the sole cause of this noisy thing. So this is really noisy. There is also a lesion right there on the bones, on the mesencephalum, temporal lobes, occipital lobes right there. There is deep white matter. There is subcortical white matter and periventricular white matter lesions. They are elongated. They are mostly related to this region, really close to the corpus callosum, and also affecting the corpus callosum, so it's okay to call it demyelinizing multiple sclerosis lesions. I don't tend to put the terminology, the term multiple sclerosis, because it's a histopathological term. It's not a imaging term. It's a pathological diagnosis, a thing you should get from a biopsy or a necropsy. So this is a clear sign of a malacia, gliosis with a central focus of malacia right there. This is a confluent lesion. There is malacia right here and gliosis right there. So this is very much worse than that first case we saw early in the stream. This a Fazekas 2 for sure, a very classic supra and infratentorial demyelinating disease, most commonly called multiple sclerosis for sure. So the rest of the brain seemed fine, nothing major. Let's see if we have any enhancing lesion. Just scroll slowly up and down, looking for enhancing sites. Not enhancing, no enhancement whatsoever on those mostly sick sites, the sites of the larger lesions. If those lesions are acute, they should show signs of diffusion restriction, and sometimes even contrast enhancement. So we have two volumetric acquisitions, both flare and post-contrast, on this November scan. Let's see the previous scan if we can see anything. Just this is the contrast enhancement from the previous scan. No, it's all right. Let's see if we have a volumetric flare on the no. Once again, they didn't do a volumetric flare previous to this scan, so we won't be able to do a proper follow-up because we can't really compare those exams, and they did even exclude the lowermost portion of the cerebellum. I'm just going to check here. So this is this. Just go for a regular flare to see if there is any major changes. Right there. It's quite similar. Right there. Let's see. Yep. Really similar there. What the? Oh, crap. This is March. So right there. There and there. That's okay. That's okay. Let's see. There on the mesencephalon. I suppose there was something here, because on the volumetric you can see this and that. and it's really the same. It's not a proper follow-up scan. I mean, it's not a proper preview scan because there was no volumetric flare, but as much as we can tell, the disease is pretty much the same. So let's grab a Fazekas 2 template. Just going to go for a right there. And let's go right there. So there are tiny, small, confluent T2 flare hyperintensity lesions all over the deep subcortical and periventricular white matter, both supra and infratentorial, and especially around the corpus callosum and the callosoceptal regions. There is even lesions on the corpus callosum itself. So this is classic multiple sclerosis, also on the brainstem and the cerebellum. There are signs of gliosis and signs of malacia right there, which is those small black spots surrounded by bright. This T1 is definitive disease right there and right there, and the flare is less definitive. The bright spots on flare usually are surrounding a definitive lesion, a cavity, a malicious site right there, there, and this is Fazekas 2 because there are small but confluent lesions. No restricted diffusion, no anomalous contrast enhancement, so it's like it's supposed to be for a disease that hasn't gotten worse as much as we can tell comparing both previous and today's exam. So let's just go for a quick and brief description. Just do a follow-up. I always write down a footnote about the follow-up findings. This is a negative follow-up because there is no change. So I just say that the current exam is unaltered. It's the same. Not going to waste my time complaining about the previous exam because it was done on the same clinic and I'm pretty sure they know they screwed up, but the patient doesn't. So it's going to be a mess just because they didn't do a proper scan the first time. And you can't really scan backwards, so why bother? You can't scan the past, you only scan today forward. So We have here a paranasal sinus scan. Let's see if we can open it up because it's really slow today. No, we didn't. We couldn't. It didn't work. So let's grab another. Let's see if we can open it up or just give up altogether. Yes, it's here. It works. This is a 60-year-old female patient. She has had a cancer of some sort on her nose, and it was surgically treated, and she has gone through radiotherapy. It was 4 years ago, and it says it's contrast enhanced. So makes sense, right? Just going to add up here that there was contrast enhancement. I hope they did it, because you know sometimes they just don't, because reasons. So we have a pre-contrast phase right here, and we have a post-contrast phase right there. I'm just going to do an MPR here of the pre-contrast because coronal view is the best for paranasal sinus, and as always, it's crooked, twisted, and looks really bad. Let's just fix the window, make it a little grayer. So this is contrast enhancement. I can see the vessels are bright, and this is the pre-contrast thingy. And it says she had some kind of nose surgery and radiotherapy. I could never tell. It seems her nose is fine to me. Nose is right there. Seems normal. Maybe there is some kind of thickening right there on her noses. Maybe a thickening here. I don't know. I can't really say. It really doesn't say much about what kind of surgery she had. So I wouldn't be able to tell. It really draws just my attention. It really draws my attention to this. It's asymmetrical, but remember this skin is crooked. It's to a side, and its skin, it doesn't, it could be just a malposition, bad positioning artifact, a artifact of a malpositioned patient. We can't really be sure. That is, let's just make it bony. And there is slight thickening of the mucosa. There is hypoplasia of the right frontal sinus. There is deviation of the nasal septum to the left. Some thickening of the sphenoid sinus, and of course the ethmoidal sinus cells are also thickened. You also have signs of chronic, not chronic, but some sort of sinusitis. Nothing major. Can't really say there is a mass of any sort here. Just going to put a coronal view here so we can be sure. So let's look for orbital, anything. Orbits look fine. Yep. Just chat. Orbit is okay. Orbit is okay. Indeed. The concha are also fine. Usually tumors, nasal tumors, are inside the nasal cavities, usually on the middle meatus, but in this case I can't really tell any signs of surgical procedure whatsoever. Maybe it was a skin lesion and the patient calls it a nose cancer. I don't know. But as much as I can tell, excuse me, as much as I can tell in this case, all we have is a sinusitis, a mild sinusitis. Nothing more than that. A contrast enhancement didn't help at all. Just another crooked paranasal sinus exam. This is a Keras type 1, most probably. Just let me measure it. Keras type 1, yes, less than 4. Type 1, mild sinusitis, a bunch of tooth implants, temporal mandibular joints and mastoids are fine. So deviation of the septum to the left and mild sinusitis. Let's just go and finish this up. Going to grab a template right there. I'm just going to add up that there is a right frontal sinus hypoplasia. It's not there. This is the most common hypoplastic sinus, facial sinus, so it's really common. And there is thickening of the mucosa of the nose and the paranasal sinus cavities. Just mild thickening. Just summarizing the scan so we can finish it up. Right there. Can't really tell anything about tumors, nor radiotherapy, nor signs of a previous surgical procedure. So it's done. It's finished. We are going to the next one now. Let's grab a dorsal spine scan if the system lets me do so. Maybe it's going to fail once again because it's extremely slow today. No, it's here. It says it's trauma. Fine. Trauma. Dorsal spine trauma. Let's see if we have anything else. No, it just says trauma on the lumbar spine. Still, they did a dorsal spine scan. So something wrong isn't right, I suppose. This is a female patient. She is 42 years of age. We are downloading it quite fast. Just maybe 20 seconds, less than 10 seconds. And we are going to be able to see whatever it is that we are supposed to see. It's just like I imagined. They didn't send any dorsal spine images, just lumbar spine. Just going to send it back so they can send a proper package of dorsal spine exam. So they sent, they ordered a dorsal spine scan, but they only sent the lumbar spine images, so we can't really work with that. See, there is just lumbar spine here, no dorsal spine, so I have to send it back so they can send the proper images to us. There is a chest CT scan right there. See if we can get a hold of it, because it's still slow. And we are already 51 minutes in, only 4 exams reported, which is quite slow. We should go for 10 an hour. So this can be a proper morning of work. It's a 48-year-old female patient. Let's see what she has here. It says she smokes, so it's a CT scan because the patient smokes. Okay, I can deal with that. That's enough for me. It's better than knowing nothing, really. If the patient smokes, it's usually a good clinical feature to be aware of. And as you guys can see, there are micronodules all over her chest, and we have to be extremely careful not to miss larger nodules. See, a tiny nodule right there. Also, we should look for signs of emphysema, cystic lesions. See, micronodules, cortical micronodules everywhere. This is really common on patients over 30 years of age, especially if they are exposed to air contaminants. Look at that. Just a bunch of micronodules all over the place. No larger nodules. Some tiny bands, which really common on the middle and the ligular lobes. Right there, a tiny one right there. This is at most 0.3, so yeah, okay with that. This is a easy one. Let's see if we have enlarged lymph nodes. No enlarged lymph nodes. Let's look for something on the adrenal glands. Adrenal glands look fine. It seems this patient has gone through some kind of contrast enhanced scan previous to this one, because see, there is contrast enhancement on the urinary tract, which is at least a couple of hours before this exam. Sometimes it's 12 to 24 hours depending on the patient's kidney function. And so it is what it is, nothing major, just micronodules, and we go on our way. I'm just going to check for bone lesions right there. Just going to do a, yep, right there, some spondylosis, some mild degenerative features on the spine, which isn't a major sign of anything really, just regular aging. So let's grab a almost normal scan template right there, and we add up those micronodules. So pulmonary micronodules on the summary of this report. And the patient can go back to her doctor and get some help. The next scan is a abdominal scan, if we are lucky enough to open it up. Yes, we did. We can report this. This is a urinary tract scan. In Brazil, it's called a urotomografia computadorizada. This is a 19-year-old female. It says she had her right kidney taken out. So I wonder what happened. Let's see if we can get some other kind of... It just says it might be a infectious disease case. It says she might have a abscess on the right side, the place she took out her kidney. Let's see if we have images. It seems this is a major case. Oh crap. It is a major case that wasn't done properly. It was supposed to be done with contrast enhancement, and it was supposed to be done as a abdominal CT, not a urotomography, because the abscess is a liver. It's a liver collection. It has right there. So, and right there, they didn't do a contrast enhancement, a proper contrast enhancement. So there is a stent, urinary stent right there. And this is just huge. This is a huge heterogeneous fluid collection. It's even hyper attenuating. Could be there is air fluid levels on such fluid collection, and it also takes a huge portion of the right side of the liver. There is pneumoperitoneum all over the place, and we have clear signs of diffuse stone disease of the left kidney. It's all destroyed by those stones, those coraliform calculi, and the parenchyma is very thin. This is probably a chronic kidney disease patient, and this is a very badly done scan on a very sick and young patient. That is also pleural effusions, bilateral pleural effusions, right there, with both atelectases and consolidations on the base of the lungs. Oh, this is so bad. So badly done. They didn't take off her metal monitoring devices, so it's filled up with artifacts. At least the appendix is fine, right? We have at least a moderate ascites. You can see free fluid right there. This should have been a contrast enhanced scan for sure. I can't really tell if we have two collections, one liver collection. This could even be a case of a diffuse liver infarction due to severe acute abdominal infection. It could lead to thrombosis of the portal vein and infarction of the liver, just like that. And liver infarction may have a air fluid level, just like that. It's possible. I'm going to measure this collection of fluid right here, and I'm going to measure this other collection of fluid right here. Clearly they had a lumbar surgery right there that went bad. So we have 1 and 2 collections. We probably have some kind of spleen necrosis, because the spleen is really heterogeneous, but it's so shaky I can't be sure. So I'm not going to risk that, because it's really easy to be wrong, and an exam is this bad. So we are going to be really brief and objective with such report. We also have enlarged retroperitoneal adenopathies, enlarged lymph nodes, retroperitoneal lymph nodes. It's right there. Just going to just write that down. 2.0. Just going to hit an MPR and measure those fluid collections, and I'm going to be as brief as I can. See, this is all necrotic liver. I really can't say this patient has any chances of surviving this. This is just way too serious. And it's really common on this kind of state-run hospitals in Brazil. Unfortunately, they just leave the patients to their own luck for days until they order this kind of crappy scans, and they do nothing, just wait for the patient to die in misery. It's really what it is. I'm sorry if you guys think I'm being harsh, but this is Brazil's healthcare in a nutshell right here. This is Brazil. Fortunately, I've seen thousands of cases such as this all over the country. This is what they do to patients that really need proper assistance, unfortunately. Let's just report it as quickly and as objectively as we can. Just finishing up. In a couple of minutes, we are going to move on to the next exam. Just need to focus a bit. So I don't say more than I'm supposed to say on this exam that is extremely badly done. Just typing in those collections. And what else? The lymph node enlargements. Right there. And this is it. The bladder is, it has a probe right there, and also the catheter, the urinary catheter, the urinary stent right there. So let's just finish it up. Just quickly finishing it up. we are done. Thank God. If you haven't already, please consider subscribing to the channel and leaving that thumbs up. It really helps getting me through this kind of terrible exam. It's just brutal sometimes, just brutal. It's just disheartening, as they say, when they can speak proper English. Not like myself, but still I'm struggling to be entertaining to you guys. This is a clear case of a impossible to report exam. This is a CT scan of the Turkish sella, the hypophysis, the pituitary gland. This is a useless exam. It never served any purpose besides making money for the clinic that does it, because you really can't see lesions on a CT scan. Most of the pituitary lesions are completely absent on CT scans such as this. So this is the Turkish sella and this is the pituitary gland on the sagittal MPR, and this is it from one side to another right here. This is the carotid arteries and the cavernous sinus, I suppose. So the pituitary is right here. This is the dorsum of the sella, and this is the anterior portion of the sella. It doesn't matter because it's always like this. It's never anything. Really, it doesn't matter if you do contrast enhancement, if you are doing a Turkish sella, a pituitary gland CT scan, you are wrong. You shouldn't be doing this. You should stop it and say to the patient he should get a proper MRI scan to try to get any sort of diagnosis, because from a CT scan, unless he has a major, huge, humongous tumor, he will not be able to have any kind of proper diagnosis made out of this kind of useless exam. So it enhances. They didn't even bother to do a phased enhancement, a multiple acquisition enhancement phase, because they know this is just a useless scan. It's supposed to be just this. It's supposed to be normal as always. So just to be sure, and it's even flagged as an emergency scan. Go figure. So not going to fight it, just going to copy and paste my template and be on my way just like that. They did it. Oh, so let's grab a knee. There is a knee MRI here. I don't know if you guys enjoy knee MRIs. I don't, but it's nice. I mean, it's a very common scan, and I suppose people enjoy them. So the me part is kinda irrelevant here. So this is a 21-year-old male patient. It's a right knee, and it says nothing on the clinical history. It says nothing on the doctor's order. It's just a good old guesswork scan. So let's take a educated guess and just try to figure out why this patient has been through this scan. So we have the patella, the femoral and the tibial extremities. I have seen already a ruptured posterior horn medial meniscus right there. So this is a horizontal lesion right there. It goes all the way to the tibial articular surface of that meniscus, and we also have a tear of the anterior cruciate ligament right there. It's gone, it's completely ruptured. So this is that classic anterior cruciate plus medial meniscus tear, which leads to surgery. It's a classic surgical case. The lateral meniscus is fine. The posterior meniscus, the medial meniscus isn't. We have a Baker's cyst right there. We also have a mild articular effusion. Patellar and quadriceps tendons are fine. I suppose there might be some kind of chondral disease right there. It's kind of shaky and noisy. Can't really tell for sure. But let's go for a coronal. Hey, I'm sorry. I'm just a bit sleepy. I did have a fairly good night of sleep, but for some reason I'm still sleepy. Maybe I'm just lazy, or maybe I should have kept myself on my diet during the weekend, which I didn't, and it just breaks me apart on Mondays when I eat crap on the weekend. Might be just that. So indeed there is a horizontal tear right there on the posterior horn of the medial meniscus, and it indeed reaches the tibial surface, the tibial site, the tibial articular surface right there. And indeed there is a rupture of the anterior cruciate ligament right there. Let's just go for the axial PD with fast saturation, so we can properly tell if there is any patellar cartilage erosion, fissure, fibrillation. This is a type 1 Wieberg classification patella, which is fine. Indeed, we have a mild articular effusion, and of course we can tell there is a ruptured anterior cruciate ligament. This is the posterior is fine, but the Baker's cyst is right here also. There isn't a lot of bone edema. I can't really say there is bone contusions nor major signs of soft tissue edema. So I can say this patient has a chronic lesion. It has been through some time of post-rupture treatment, maybe some physical therapy and icing this knee, so it's really not swelling at all. It's just this might even be a pre-surgical assessment. They usually treat ruptured anterior cruciate ligaments clinically, and then they do surgery when it's just like this. There is no residual edema, not a very profuse effusion, when it's just like it's not a really inflamed joint, so this surgery can go much easier than if it's an acute lesion right there. So this is ruptured. It's clearly ruptured right there. This isn't properly positioned, but it usually isn't, so we just get used to it. So it's a posterior horn medial meniscus tear and a anterior cruciate ligament tear, a Baker's cyst, and a small articular effusion. No chondral lesions, no hypertrophy, no soft tissue edema. So let's just write it down. Baker's cysts, and we have a tear of the posterior horn of the medial meniscus. Anterior cruciate ligament is ruptured, and this is it. Just summarizing it to make it easier for the referring physician to read the report. So staying on my screen. Gotta clean that up. And we are done with this. This isn't a emergency scan for sure, but it was flagged as emergency, so we got it. We have a lumbar spine. Lumbar spines could be indeed emergency scans, I suppose. It's loading. It's here. It says it's a 76-year-old patient, and she has chronic kidney disease, and for some motive, for some reason, she's been scanned for her spine, and it says he has a very odd name that I just couldn't say it was a male, but it is a male, and he has prostate cancer. This exam is of the spine. He has both prostate cancer and chronic kidney disease. He goes through dialysis, and they did it in an enhanced scan of his spine. I suppose it's to look for some sort of secondary bone disease. This is just a bizarre scan. We really aren't going to say much because we don't have contrast enhancement, and this patient is really sick. I can say this is 5, 4, 3, 2, and 1. There is an old collapse of L1. The discs are all screwed up. We have extrusions all over the place. We have a fluid accumulation on this disc right there. We have, do we have They did a diffusion weighted sequence. I suppose they are trying to say if this is infection, but they did it the worst way possible. Let's see right there. Oh, they did a diffusion and it's really bright. It's just too noisy and shaky to be sure, but whatever. Did they do a, I don't know, what is this? This is supposed to be the steer. So steer and diffusion weighted. Oh, no ADC map. Oh, the ADC map is really bad. Supposed to be, it's B50. This is the B60. Right there is there. I suppose there is some restricted diffusion, a broad diffusion, restricted diffusion right there. Though this could be indeed infection. I suppose it could be. There is stenosis right there. And there is diffuse atrophy of the muscles. There is synovitis of the facet joints. And indeed, there is some very severe. The paravertebral muscles are also atrophic. It's funny because kidneys seem fine, at least in size. So we have a very diffuse, indistinct diffusion weighted artifact right there that confirms this site as infectious in nature. So it's called the claw sign, and really aren't really lucky today. We're just getting this very sick patients to report. I'm just getting, I don't know, some Mondays are like this, worse than others, and we just have to fight through them. This is L2, L3. So the really bad infectious site is L2, L3, and the collapsed segment is L1. So let's go. Let's grab a template of a very sick scan right there. I'm just going to add that we did a DWI sequence, a diffusion weighted sequence. Just right there. And we're going to report the osteophytes and the collapse of the first L1 body. So there was a node fracture and a partial collapse of L1. This site here, we have the claw sign, we have liquid fluid accumulation on the intervertebral space right there. We have bone edema that is clearly seen in STIR, STIR, or T2 with fat saturation. And on diffusion weighted, in a diffusion weighted sequence like this, there was supposed to be a very well defined line that would tell us it's just degenerative, but since the diffusion weighted artifact, the restricted diffusion is diffuse, is irregular and really thick, it's much more probable that this is indeed infection, which is a very common disease on such immunocompromised patients. This patient has cancer, advanced cancer, and is also has also chronic kidney disease. So this is Spondylodiscitis. It's a infection of the bone and the intervertebral disc on L2 and L3. There is and there is extrusions on every single segment, so we are going to report that also. There is atrophy of the muscles. Let's just see if we have neural foraminal stenosis. We do. Mild stenosis on L2, L3, and L3, L4 on the left. And we have some sort of vertebral canal stenosis right here. This is moderate. This is mild. This is mild. This is normal. So moderate of L2, L3, L3, L4, and L4, L5. It's mild. And there is a diffuse anomalous distribution of the neural roots, probably due to the infection. This can be quite painful by itself, so we have to report that also. It goes from L1 right there, see, to right here, L4. So let's just summarize it to make it easier for the referring physician to read it. Old fracture and partial collapse of L1. Just extrusions all over the place. Let's see how bad is the arthrosis. I could say it's severe. Why not? And the stenosis, all the stenosis and the atrophy of the muscles. Right there. Could be due to a inflamed a infectious disease of the neural components of the vertebral canal from here all the way to around here, like that. This isn't really, this is one of the worst looking spines I have ever reported. Seriously, this is just awful. Crap. Just going. Oh, right. Just hit the wrong key right there. So I'm just going to read it to make sure I didn't miss anything. And we are done. Thank God. Did I make it? Oh, it's without contrast enhancement, of course. Just clean this up. And we have a brain CT scan just to take a breath and report something easier. It's a 48-year-old female. It says she had some kind of, she wasn't feeling well. She had some subtle, she felt very bad, very subtly, very unexpectedly 2 days ago, and now she got a brain CT scan that was done on a very old and oh crap. Oh, this is just brutal. This Monday is one of those, guys. See this and that? This is not a stroke. This is definitely not a stroke. This is not a proper arterial territory. This isn't even properly scanned. We have no contrast enhancement. This is a very, very old scanner. This is a very low quality scan. We have no contrast enhancement. We have no proper clinical history. Still, we have a lesion right here and at least 2 more lesions right here on the frontal lobes. This is most probably a case of secondary disease, metastatic disease, but we have no proper history. We have no proper images. This is a very poor scan, and we are just going to report it as we are seeing it because there is a tiny calcification, but I couldn't just not say that this isn't a secondary disease. They just ignored the fact that the cerebellum didn't end here. Just this one of those scans we are so used to report. Right there, see, this is probably tumor surrounded by edema. There is probably something else here that I can't really tell. And of course, on the nucleocapsular region right there, there is another lesion right there. This isn't stroke. This can't be stroke really, because this isn't a proper vascular territory. I suppose it's just as soon as they do a proper exam on this patient, she is going to have a very, very scary conversation with her referring physician. I'm just going to report it and suggest they should get an MRI with contrast enhancement. Right there. Just finish it up. Just saying they should get an MRI. There are 2 frontal lobe lesions and 1 basal ganglia lesion on the right. And we are done. Not even the CT scans of the brain are easy today. This isn't really a very easy Monday for sure. So let's grab another knee exam. We have already reported 10 scans today. We are going slow and steady. If you guys are enjoying this, just hit that like button and consider subscribing to the channel. It helps a lot to keep me pushing through doing these live streams. I'm trying to live stream every day starting on this week. Being kind of difficult to keep stuff together and live stream. Right, this is sagittal PD with fat saturation. This is coronal PD with fat saturation. I can already say there is arthrosis, mild arthrosis of the patellofemoral compartment. There is mild tendinopathy or tendinosis or tendinitis of the quadriceps tendon right there. There is thickening and diffuse signal heterogeneity of the proximal extremity of the patellar tendon. There is some edema of soft tissues all over the joint. This is artifact, saturation artifact. The meniscus seem fine. Yep, anterior and posterior cruciate also fine. Yes, arthrosis on T1, that is very clear. Seems like this is it. On coronal, the meniscus seem fine. This is a 4.3 thickness scan, so this is a very poorly done scan. This really isn't supposed to show much because it's too thick. It's just one of those scans that only show gross disease. It doesn't show small disease, doesn't show tiny features of disease, just low quality, low cost scans. So there are deep erosions on the cartilage of both the femoral trochlea and the patella. There is subchondral edema, also osteophytes, and decreased articular joint spaces, narrowed joint spaces, which are the plain old description of arthrosis. And by looking at it, I can say it's mild. Another doctor could classify it as moderate, or I'd rather say it's mild, especially because the rest of the knee seems fine. And we don't have a proper scan. We just have this poorly done scan right there. There is a small effusion right there. See, a small joint effusion with blurred margins, which tells me there is synovitis. So no Baker's cyst, and the collateral ligaments seem fine. So let's just grab a template right there, and I'm just going to write those findings down so we can go to the next one. This is it. Small articular effusion and synovitis right there, and thickening and diffuse signal intensity changes on the proximal extremity of the patellar tendon and the distal extremity of the quadriceps tendon. Right there. Edema of soft tissue right there, right there. there is indeed some edema. It is a swollen knee. Meniscus are fine. Cruciate and collateral ligaments are fine. And this is it. Mild osteoarthrosis of the patellofemoral compartment or joint. Mild diffusion and synovitis. We have a moderate tendinitis of the patellar tendon. And mild of the quadriceptal tendon, and some mild edema of soft tissue right there. It is a surgical case, not so much, but it is indeed a chronic knee. It will eventually turn out to be a candidate for a knee replacement surgery. Next exam in line is a shoulder MRI. A shoulder MRI. I'm going to bring it up. It's here, just downloading. It says this is a 63-year-old male, and there is no clinical history whatsoever, so we are up to guesswork to help us out. So this is what radiology usually is, just educated guesses, struggling with very poorly done scans. This is a horrible scan. It's a really bad scanner with a destroyed coil and very malpositioned patient and a very severe disease. There is a complete tear of the subscapularis tendon right there. There is a advanced degenerative disease of the biceps, long head biceps tendon right there, which is dislocated medially and goes through the site of rupture of such subscapulary right there. There is clear arthrosis of the glenohumeral joint. There is probably rupture of every other tendon of the shoulder. Yes, there is rupture of the supraspinatus right there. Infraspinatus. Yes, the infraspinatus is also ruptured. The teres minus is there. Let me see if they have a they have a sagittal. So there is a lot of edema. It's a really bad exam. So the supraspinatus is ruptured, the infraspinatus is ruptured, and the subscapulary also, and the long head biceps tendon is right there, but it's medially dislocated because it has gone out of its sulcus, which is there because of the rupture of the supraspinatus of the subscapularis. There is edema of soft tissue and muscles, and there is also atrophy of the muscles. This isn't properly scanned, of course, but there is hypertrophy of the entirety of the muscles of the shoulder. It's the rotator cuff, as it's called. There is also moderate arthrosis and synovitis of the acromioclavicular joint. There is bursitis. There is a large effusion Let's see on the sagittal and the coronal view if I can say there is a glenohumeral arthrosis. There is glenohumeral arthrosis. There is a large rupture of the labrum right there. It's all fuzzy and heterogeneous. It's all destroyed. So this is a very, very sick patient. This is a destroyed, screwed up shoulder for sure. This is a huge mess, a humongous mess right there. Let's report it as much as we can. I have a template that says most of what I just told you guys, so I'm just going to improve it to adding stuff I just find out and describe to you guys. So the articular effusion, the ruptured glenoid labrum, so this is it. Arthrosis, rupture of the subscapularis, the supraspinatus and the infraspinatus tendons, severe tenosynovitis of the long head biceps tendon, which is medially dislocated through the rupture of the subscapularis, and also bursitis, articular effusion, arthrosis, all that good stuff, hypertrophy of the rotator cuff muscles, all that good stuff. So since I had my template and I have seen cases such as this 1,000 times, not as bad as this, but close enough, it wasn't really hard to properly report it very quickly. And it's critical for sure. Let's just send it back and grab a lumbar spine to see if we have any luck reporting at least one good easy scan this morning. We are already up to 12 scans. So this patient has done a lumbar spine. She is 72 years of age, and there is no clinical history as always. Some kind of pain on her right side, right inferior limb. So let's load it. Oh crap. See how bad the skin is? It's just dark. It's just this is a very bad coil and a very old scanner. This is really bad. So I suppose this is a T2 scan, T2 sequence of some sort. This is supposed to be a T1. Just going to window it till we can see at least bone right there. And they also send a supposedly fat saturated tissue. That is just black noise right there, black noise. It's really not of any use. And they did some kind of reformat right there. The field of view is too large. The patient is clearly obese. The scanner is old. The slices are 4.5 millimeters thick. Still thick. It's just this is just the worst way to do a lumbar spine scan. It's just make believe. It's just a make believe scan of an old patient that has some sort of allegedly right-sided inferior limb pain. There might be some kind of edema on the vertebral body. This could be just artifacts. I suppose this is a axial T2. It is a axial T2. There is thickening of the yellow ligaments, at least moderate, severe to moderate arthrosis. They ended up too early, but I can see there is hypertrophy and fat infiltration of the muscles. I can say there is some protruded disc right there, maybe here and there, here and there also. There is a slight anterior dislocation of L4 if compared to L5, because this is the worst size of facet joint arthrosis. So there is some kind of hypermobility here. This is a hemangioma. I'm not going to report that because reasons. It doesn't show on the M2 on the axial because the technician thought it wasn't of importance, so I'm not going to report it either. And T1, yep, it's definitely a hemangioma 1.2 on L2, 2, 3, 4. No, it's 3, 4, and 5. So we have everything we need. The neural foramina are fine, and as much as I can tell, the vertebral canal has no critical stenosis, just regular degenerative disease. We're gonna call these two protrusions if broad base, and these two protrusions focal and foraminal in nature, and we're gonna call this arthrosis severe. And let's go. I have a template that is quite like this, so we can report it really quickly right there. There is a anterior dislocation of L4. It's a grade 1. Right there. This margin is slightly anterior to this margin right there, so it's grade 1. And we have L1, L2, and L2, L3 protrusions. And we also have L3, L4 foraminal protrusions. No stenosis, just hypertrophy of the muscles. Just severe arthrosis. Right there. Fine. Did I miss anything? No. Just that. And we are done. We are free. Let's grab now another lumbar spine. Are we going to be lucky this time? I don't know. Maybe not. Just going to finish up my water here. It's taking really a lot of time to show me the report thingy, and we are 2 hours in already. Thank you so much for liking and subscribing to the channel. We are I'm trying to stream every day from this week on, so the more you guys share this video, the more someone will show up doing live stream, and I'm not going to be speaking to myself. So not speaking to myself during the entire stream helps a lot, especially to make it less boring. This is a 65-year-old female, and it says nothing. Let's just see if we can. It says she has some lumbar disc disease and vertebral canal stenosis. Oh, it comes from the same place of that previous scan, so it's a very badly done scan, just as crappy as they come. Right there, this is supposed to be a T2 scan. It's a very large, obese female patient, and the scanner is old and badly maintained. Clearly a very, very bad scan. This is a T2, a regular T2. This is supposed to be a fat saturated sequence of some sort. I can clearly see this is edema right there and right there and right there, there and there. So we have MODEC 1 and 2 at least all over the place. We also have some sort of articular effusion on a bunch of facet joints, which is also painful. Let's grab a T1 just to be sure. Yes, black on T1, and it's bright on flare on T2, and STIR, STIR. So it's really edema. It's painful. On axial view, we can see there is hypertrophy and fat substitution, fat infiltration of the perivertebral muscles, and the technician once again stopped the scan way too early. He should have done a couple more cuts, got more slices downwards, and at least another slice upwards. They are saving time by doing a extremely bad scan. So they say it's for the best, but I doubt it's for the best interest of the patient, and it surely isn't helping me much. So someone is winning. It's just not us, guys. Just not us. This is how life is. We have a moderate stenosis right there and a mild stenosis right there. I'm just going to call it mild and bilateral because two sides of the roots are in contact with other structures inside the neural foramina right there. So we have diffuse bulging discs from L1 to S1 and extruded components right on the posterior aspects of such discs. This is a very common case of very old lumbar spine of a very large patient. Hello, good morning, what's up? Just taking a template and right there. Just going to report the neural foramen stenosis. L5S1. And we are done. Just summarizing now. So we can go to the next one. Which fight? The Tyson fight? Oh, I didn't watch it properly. I just glanced at it for a few moments because it was so bad. The first couple rounds was so bad, I just gave up on it, and I looked it up on Google, and it says Tyson had lost, and I just immediately remember why I gave up on watching boxing fights, because it's all the same. It's just made up crap. Maybe because they bet so much on it, so they just do that hyping thing. They just hype it as much as they can, and when it comes to the actual fight, it's all fixed and it's no fun. It's just making stupid people, just making a ass out of people. It's just, I didn't waste my time on it. I as soon as I glanced at the couple first rounds, I knew it was fixed, so I just gave up on it. I do watch BJJ matches, especially those classic matches and those super fights, because they tend to be real. But I suppose those fights too, sometime in the future, when bets are high enough and people are greedy enough, they too much might be fixed, and we are going to be left with just those regular local championship fights. Major things on TV are usually just fixed crap. I really had some hopes Mike Tyson would be at least 10% of what he was back in the 90s, but no, it was just a wild dream after all. Too bad. I really think if he gave his best, considering how much steroids he was taking and how badly it seems he was training. I thought he could actually beat the other guy, the YouTuber guy, but no, it was just crap. Which one's my UFC fighter? My favorite. I don't really watch much UFC, but I can't really say I'm not really into that since Anderson Silva broke his leg and started losing every fight. He was the last fighter I actually followed on social media and the fights, the preparations. But I can say Alex Poitin is a really nice fighter to watch fight. Yes, I know he's 58, but you know, it's Tyson, right? And the other guy isn't really a boxer. It's just an amateur. And Tyson was once a top professional. I don't know. 58 is a lot, I suppose. Still, it could be a nice fight if they didn't actually fix it just to get money out of people, as it's clearly stated everywhere on the net right now. So I think Alex Poitin is a different kind of kickboxer. I have trained a bit of Muay Thai myself, and he does indeed kicks and punches in a very peculiar way. So, and it's really clear that he studies his opponents and he feints and punches and kicks to get open guards and do massive blows. It's really he is really a smart fighter, a clever fighter. So it's really nice to see him fight, at least the highlights. But I'm not really looking forward to any UFC. I'm much more into BJJ now, since I've been taking classes with my kids for the last 4 months. So it's nice to watch people fight and see how they move, because BJJ as a white belt is almost as tough as streaming on YouTube. It's almost as frustrating as streaming, I have to say. So you have to grab yourself onto something to have some hope to improve and keep pushing through the adversities and the frustration of being tapped out multiple times every single time you practice. And every now and then you get a black eye like I did, and your family spends 10 days mocking your face out. And you have to take it in some sort of happy way, because you can't really do much about it. So my wife has practiced Muay Thai and Chinese boxing and a bunch of other stuff, and she is the first one to tell me I'm not supposed to be beaten up practicing a sport. So, but that's BJJ. BJJ is getting beat up until you are good enough to beat up other people. That's how you build your technique and strength, is by getting tapped and subdued and taken down and swept and swept, I guess. Those chokes and arm bars and footlocks, all that fun stuff. So this is a 77-year-old female. It says she has breast cancer, so she's getting a MRI scan for staging. Besides old age, I can't really say much. She has some slight tiny spots of gliosis on the white matter, nothing major. A slight mild dilatation of the ventricles and reduction of brain size and volume right there. The hippocampals are fine for her age. Maybe this is an MTA2 classification. Diffusion weighted sequence seems fine right there. This is a SWI sequence for mineral blood products and calcifications. No deposits, no signs of old disease. And of course, we have a sagittal volumetric acquisition. Post-contrast, this is a T1 post-contrast phase. Let's just go slowly to see if we have enhancing spots that could point us to secondary disease. Also, you have to remember breast cancer secondary disease can present itself just by a thickened and diffusely enhancing meningitis, carcinomatous meningitis. It's usually both pial and pachymeningeal enhancing. This isn't really enhancing much, just this is mildly enhancing on the frontal and parietal lobes, nothing that draws my attention as pathological. No thrombosis, no sites of enhancing lesions on the brain. This is a coronal for some reason. Flare is fine. Just going to grab a flare. It's here, but just to be sure. No? Okay. T2 and flare side by side just to finish it up so we don't lose much. No, it's fine. So I have a template for this. This is a very common exam. This is a Fazekas 1 gliosis plus a mild reduction in brain volume. So I have this. Just going to adding the hippocampus phrase right there. It's MTA2. Just summarizing it so we can go to the next one. Right there, we are done. Let's just finish it up right there. And let's grab another one. It's loading. I'm just going to grab more water. I'll be right back. Don't go away. I'll be back. And we are back. Just cup of water, glass of water right here. We are out of coffee temporarily. Just let's. And I had my third kidney passing this last week. It was a 0.2 micro calculus, a 0.2 centimeter stone that went through my right kidney all the way to my bladder, and it was terrible as always. I had almost 3 hours of excruciating pain until it got through. I had already a fellow urologist ready to take it out, but I just had dinner right before it started aching like hell, so I had to wait 8 hours to go under anesthesia and have it taken out. And lucky or not, in just under three hours it got out by itself, and I was back on my feet. It was last Thursday night around 8 o'clock in the evening, and it got me for almost 3 hours. I was back home about midnight, and I was feeling like shit because I had morphine and a bunch of other stuff because it was hurting like hell. It was clearly the worst of my 3 events. I've had another one like 5 years ago, and I really don't remember it being so bad. This time it was the worst for sure. So I have to get back to drinking more water, and I have to keep myself from dehydrating when I go to BJJ practice. I suppose it was a major factor, being dehydrated for hours 4 times a week, because BJJ makes me sweat like a pig. So if you are sweating like a pig and not drinking a bunch of water, you are going to have, at least me, I am going to have more stones, and I don't want to go through that crap again. So this is a CT scan of a 55-year-old male. It says he has some kind of stroke. I can't agree. I think he is fine. No signs of stroke, at least not a stroke that I could see. Oh, this is one of those. This is one of those difficult to window exams. So let's not going to stress myself out. There isn't even calcifications, arterial calcifications, just a good old normal brain. So no stroke, normal exam, thank God. First one of this morning. It's not, I can't complain. Just send it over and go to the next one. If a doctor refers a patient to get a MRI brain because of memory loss, is it a good idea to also include T2 thin coronal hypothalamus slices Or is it irregular T2? It's supposed, no, you are supposed to do. If it says memory loss, you surely should get a coronal T2 for hippocampus, not hypothalamus. I suppose you meant a hippocampus. Those temporal, mesial temporal lobe coronal, those you scan just like this. Just grab a, this is a CT scan, but I could just it's just anatomy, right? So you do go like this, and you do a scan just like this. You go from here to right about there, like this. So those coronal hippocampus sequences, T2, it could be a T2, it could be a flare, or it could be also a IR, a inversion recovery T2, that makes cortical and white matter much well defined from each other. So you could do one or two or three of those sequences, but if you only have to do one, I'd say you do a coronal T2, and it's fine. It's okay. It's useful. Usually we have some kind of we are looking for the referring physician is looking for some sort of dementia related illness, so it's nice to have a coronal hippocampus sequence to rule out or ruling Alzheimer's disease. It's also nice to have that, and a flare for epilepsy. If it says epilepsy, seizures of some sort of of epileptic disease or suspected epilepsy, something like that, it's nice to do both a T2 and a flare. So this is another spine MRI of that place that has a very old and mal maintained scanner. It says here this patient is 69 years of age, and there is no history, no clinical history. It just says she has lower back pain, and it's mostly on the left. So as you guys can see, this is chronic. There is some sort of right there, maybe some edema right there, some modic 1 and 2 could be. There is mild protrusions. See, maybe an extrusion here. The field of view is too big, so resolution is quite low. We could say from L3, 4, and 5 to S1, protrusions 3, protrusions right there. The neural foramina seem fine. Maybe there is a mild stenosis here. Maybe mild stenosis here, so we could say that on L5, S1. Let's just see the axial. There is a kidney cyst right there, which I'm not going to report because this isn't a abdominal scan. This is a lumbar spine scan. So chronic denervation all over the muscles. This is severe arthrosis. Stenosis of the vertebral canal. There is clearly thickening of the yellow ligaments, and indeed we can say there is stenosis of the neural foramina on L5S1. So this could be a justification, a cause, a reason for this patient's complaints. Let's grab a template. I have a template for this right there. So the three last segments, the three inferior segments have protrusions. There is mild stenosis of the vertebra, the neural foramina of L5S1. Yes. The rest is fine. And we are done here. Why not? Just severe arthrosis and mild stenosis. Right there. We are done. So I think we are getting faster in this reporting business. We are already 17 scans down. I had just another lumbar spine, but it seems they have sent me another one. It's a 78-year-old female, 78-year-old female. It's a lumbar spine. Let's see what it says here. It says she has pain on her lumbar spine and her right shoulder. Never gone through surgery. So it's what they always say. And they did a coronal that serves nothing. It's just a waste of time. We have a acute fracture right there, another acute fracture right there. How acute is it? It's very acute. See? Also acute. It's an acute fracture in a collapse of D12 and L1. This is 2, 3, 4, and 5. So no shit, she is in pain. This is usually related to osteoporosis. So this is a insufficiency fracture. A fracture due to overload of the spine in a osteoporotic patient. It's a fragile patient, and this is clearly shaky. A fragile patient that had an acute insufficiency fracture. Did the fracture reach the pedicles? Can't really tell because resolution is awful. Can't tell. I'll just refrain myself from saying much more than just a vertebral body fracture. This is also shaken and it's malpositioned. So this patient was clearly in pain. They tend to send patients to MRI without proper pain management. Go figure why, because the exam is really bad. Let's just grab a template. There is hypertrophy and fat substitution, fat infiltration of the vessels or the muscles. Also severe arthrosis and synovitis right there. There is joint effusion on a bunch of the joints right there. So there is synovitis, thickening of yellow ligaments. Are there stenosis of neural foramina? No stenosis, definitely not. But there is fractures. There are fractures. Protrusions? No. Maybe. Maybe a tiny protrusion right there and tiny excuse me, foraminal protrusions right there. So this is 1, 2, 3, 4, and 5. So the protrusions are really the cause of the pain this patient is complaining about. So let's just report the fractures. Let's see the protrusions. This is right. This is left. Maybe there is a mild protrusion right here, right there. Maybe, I don't know. Just, I don't know. This isn't really an easy call because it's too crooked to be sure, but I'm going to call this central, paracentral foraminal to the left. And this is also, is this real? I don't know. This just looks like thickness artifact, slice thickness artifacts. I think both these segments have the same kind of protrusion. This is 1, 2, 3, 4, and 5. Is this to the left? Yes, it's to the left. Oh, small protrusions, thickening of yellow ligaments, arthrosis and synovitis of facet joints, hypertrophy, yellow ligaments, and we are down. Just summarizing. Protrusions. And we don't know proper stenosis, just good old insufficiency fractures. Right there, we have a CT scan of the brain. I remember when I had a patient with a severe compressed fracture, they couldn't get up. Yes, it happens a lot, mate. A lot. It's really hard to move those patients. They are usually in quite some pain, especially when they are big and old. They are heavy and they are really desperate. It's really a painful. It's even painful to watch. It's really, those cases are terrible. And they are one of those very rare cases that a MRI scan is actually a emergency scan, because sometimes those cases are surgical and the patient won't get better unless the orthopedic surgeon intervenes. So it's really a thing that we can't just say, oh, go back to the ER and get some medication and then you can do an exam. You have to try to make the scan as best as you can, because you know it might not get better no matter how much medication that patient gets, because his or her spine is all unstable due to those fractures. Yes, yes. It's sometimes you have to let them get up by themselves, because when you try to help, it just hurts more. But sometimes they just can't get up, and they have to be transported to a stretcher, just like those major trauma cases. And they are really bedridden. They are really restricted to bed rest, because if they put any kind of stress on the fracture site, the pain is just excruciating, it's just unbearable. So those cases are really, really that bad. I see you. I've been there a lot. I used to work on the ER. I used to work shoulder to shoulder with my fellow technicians, and it was tough. It wasn't pretty to see, for sure. So I have a CT scan, a brain CT scan here. It's a 53-year-old patient, and it says he had a seizure. So let's go for epilepsy on a CT scan. No contrast enhancement, just plain old guesswork. Let's see if we can see anything. I don't know if it's the first time this patient has a seizure, or if it's just a a common event. It seems he has some sort of left temporal lobe atrophy right there. See? This left temporal lobe isn't normal. Could be sclerosis, could be some sort of scar tissue related to a previous trauma. Usually brain contusions are on the frontal lobes and on the temporal poles right there. So this is a very common site of scarring due to trauma. He has a very ugly and twisted nose. Seems like a previously broken nose. Also, he have a deformed right side zygomatic arc, which also looks like a fracture, previous fracture, and his left zygomatic arc is also crooked. So this is probably due to trauma. This is also a shaky, malpositioned exam. So indeed, this might be just yet another case of someone who fell from his motorcycle, crashed his skull on the road, had a major brain injury, and later on got to be epileptic due to brain scars. So let's just do a MPR so you guys can be satisfied with this scarring tissue right there. See, this is all scar tissue, malacia, gliosis right there. This is the superior gyrus, temporal gyrus. Maybe the middle gyrus is also affected. Can't really tell because this is a CT scan, a crooked one, but indeed there is malacia right there, and it's more than enough for the patient to have an epileptic seizure. See, this seems like scar tissue on the skin of the scalp, and clearly he has some facial deformities related to fractures, to old fractures. He has also an orbital fracture right there. So he is indeed a patient, a trauma patient. Missing teeth, broken teeth all over the maxilla, sinusitis, and whatnot. So let's go for it. Let's just finish this up and go to the next one. It's other calcifications on the vessels. No, so this is almost a normal exam. So left temporal lobe, it's down. Yeah. I usually read from 50 to 70 studies a day from home. I aim at 50, and I try to push myself to go to 70 as much as I can. I didn't have much luck since Thursday of last week because I had the kidney thing, and I was in pain and I was really tired the next days, and it was Saturday and Sunday, and I had to be with my kids and my wife. So, but I aim at 50 to 70 each day, so I can reach around 1,500 a month. Oh, I had a passing stone, a 0.2 passing stone on my right kidney, and I had to go through 3 hours of excruciating pain to get rid of it, and it was just awful. So we are almost 3 hours in already. Thank you so much, guys, for watching. Just hit that like button and subscribe to the channel. I'll see you guys tomorrow. I'll be streaming tomorrow afternoon, and I'll be sure to leave a schedule stream earlier tomorrow, so you guys can set us know around the time I'll be on, depending on where in the world you guys are at, because here in Brazil the schedule is kind of funky if you compare it to other parts of the world. So thank you so much, and I'll see you in the next stream. So long.